you all in today's scientific session. Today, our chairperson, Dr. Subhash Kumar sir, who is an MBBS MD, MS Endocrine and Diabetes from London, RCGP Royal College in UK. He is also the Director and Chief Endocrinologist, Diabetes and Obesity Care Center, Patna, and is also a consultant to UNICEF and Sahयोग Multi-Speciality Hospitals, Patna. Today, our two eminent speakers, Dr. Chandan Kumar sir, as well as Dr. Ajay Kumar Sinha sir. Dr. Chandan Kumar sir, who is an MBBS MD DTCD Patna, who is a renowned consultant physician, Sri Krishna Diabetes, Thyroid, and
I'm
Chest
not getting you.
Patna. Now I handed over the session to Dr. Subhash Kumar sir. Subhash Kumar sir,
Yeah.
over to you, sir.
Good evening,
Good
friends.
evening, sir. Good evening.
Good evening. Today we have two very important topic, especially on cardio-diabetic issue. And as you know that this COVID situation has really changed the whole scenario of our daily routine as well as medical science. And we have to always upgrade ourselves with the newer information and newer risk factor, or maybe a more stringent risk factor and related issues. So today we have Dr. Chandan Kumar, who is going to talk about the risk factor in CVD, and followed by a talk on heart failure, which is a very pertinent topic in today's scenario. So without wasting much time, I'll ask Dr. Chandan Kumar to share his presentation and start the talk.
Yes, sir, is it presentation is visible to all?
Not yet. You need to share it.
Sir, kindly share your screen, sir.
Okay.
Just click on the green button, Chandan.
Yes, sir. Green buttons on.
First,
on
open your presentation on your desktop. First, open
Yes,
your
sir.
PPT. Okay.
Yes, sir. It's open, sir. It's
Now
open.
you click on the green button, share screen button.
Actually, it's not coming on my upper side. It is not coming.
On the lower side, it will come where it is shown your participant chat, and then there is a share screen.
Live. Okay, sir. Is it?
Yes.
Is it visible, sir?
Okay, it's visible.
Yes, sir,
now
it's visible.
make it on. Okay, it's already on us. Yeah, full screen.
So should I start, sir?
You can start now.
Okay. So good evening to all of you. Here, myself, Dr. Chandan Kumar, who is practicing as a consultant physician in Patna. I'm going to present one very important topic, that is hypertension in patients with coronary artery disease. As you know, the hypertension is as common as anything, and the coronary artery disease is very common. So it's important to manage the hypertension in patients with the coronary artery disease. Hypertension is a major independent risk factor for the development of coronary artery disease, stroke, and the renal failure of all ages, races, and sex groups. So it's one of the most important risk factors for the cardiovascular disease as well as stroke, renal failure in all ages and all races and all sexes. There is a strong interaction between hypertension and other cardiovascular risk factors, and the risk attributable to hypertension for coronary artery disease is much greater in people who have other additional risk factors. So we should not view the hypertension as isolated disease, because once it's not isolated, the patient always comes with the varieties of other risk factors as well as hypertension, other disease also, where you can have the different kinds of diseases in the patient. So you should not view this hypertension as an isolated issue, and it's a complex entity of risk factors, which we should be more aggressive in hypertension control in presence of other risk factors. Sorry. So if you see the lifestyle, these are the modifiable risk factors, which is diet, physical activity, smoking, drinking, alcohol drinking, stress, and others. The genetic factors, which is a non-modifiable risk factor, unmodifiable risk factors, and the risk factors for the coronary vascular disease, which is hypertension, dyslipidemia, diabetes, hyperuricemia, obesity, and others, which may lead to the CVD, stroke, and coronary heart disease. So this is very important. So when you this is the primary prevention, and then the secondary stages, where you can prevent the progression of the coronary vascular disease, and the most important one is stroke and coronary heart disease. So these are the important that if you manage this lifestyle risk factors, if you manage the hypertension, if you manage the dyslipidemia, diabetes, hyperuricemia, and obesity, the chances of progression to stroke and coronary heart disease is less. So cardiovascular mortality risk doubles with each 20/10 mmHg BP increment. So as anyone is having hypertension and the hypertensive, the blood pressure in the above range, in the above normal range, more the blood pressure, the more the chances of cardiovascular mortality risk. So it's very important to understand this fact and to control the diabetes, to treat the diabetes as well as other risk factors of hypertension. So epidemiology of hypertension and coronary artery disease, the prevalence of hypertension is directly proportional to the age of the population. So as your age advances, even though you are living with all the good quality of life, but the chances of hypertension increases when your age increases. So estimation according to the Birmingham Heart Study, the remaining lifetime risk of developing hypertension is almost around 90% of men and women not yet hypertensive by middle age. So what is the relationship between age and coronary artery disease? The diastolic blood pressure elevation predominating in young hypertensive individuals, and the systolic hypertension often in the isolation is systolic hypertension emerging in older ages. So before 50 years of age, diastolic blood pressure is a major predictor of ischemic heart disease risk, whereas after 60 years of age, systolic blood pressure is a more important. So you should understand that where the diastolic blood pressure is major predictors and the systolic blood pressure is major predictors. In patients with more than 60 years of age, diastolic blood pressure becomes inversely related to coronary artery disease risk, and pulse pressure becomes the strongest predictor of coronary artery disease. So meta-analysis of 61 studies, including 1 billion in adults, the BP was related to fetal coronary artery disease over the BP range of 115/75 to 185/115 mmHg for all ages. Each increase in systolic blood pressure of 20 mmHg or each 10 mmHg increase in diastolic blood pressure doubles the risk of fatal coronary event. So this is very, very important. For any given systolic blood pressure, the risk of fatal coronary artery disease was 15 or higher. People 80 to 89 years age and for those 40 to 49 years of age. So the relationship of age and coronary artery disease is very strong. So epidemiological data shows that the lower blood pressure levels are associated with a lower disease risk. suggesting that the future coronary events can be prevented by reducing blood pressure. So it's a very important. Calculating senior risk coronary heart disease is using point code. There are different points that is given for age, for the cholesterol, for the smoker or not a smoker, HDL, systolic blood pressure, and overall you can calculate the 10-year risk according to this risk minimum point score, and you can understand whether a score in which category the patient is. So, mechanism of hypertension of coronary artery disease. A variety of pathophysiological mechanisms contribute to genesis of blood pressure elevation and related target organ damage, including coronary artery disease light. In sympathetic nervous system and RAS activity, which is one probable cause of pathophysiology, one probable pathophysiological approach. The deficiencies in the release of active vasodilator, for example, nitric oxide, NO, and post-affecting, which are important vasodilators. Change in the nitric peptide concentration, increase the expression of the growth factor, and inflammatory cytokines in the artery. Then hemodynamic effects are the important probable pathophysiological mechanism. And functional abnormalities in conductance and the resistance arteries, particularly increased vascular stiffness, may be dysfunction.
Chandan, your 1 minute, Chandan, your voice is little cracking. So I think
yes.
I don't know, it is on my side or what. You can just video your video, no? You can just mute your video so that the voice becomes more clear, if at all.
Okay. Okay.
Just keep your voice on. Maybe. Is it for everybody or it's only for me?
Voice is echo, sir.
Okay. So, okay.
Now, sir, is it okay?
Yeah. Go ahead. Let's continue. Okay.
Now it's okay, sir. You can continue.
Yes. Continue your presentation.
Non-molecular risk factors. Another one is molecular, sex, race, ethnicity, dyslipidemia, those patients with the coronary vascular disease and age less than 75 years with ideal cholesterol more than or equal to more than 190 milligram per deciliter, or the 10 years CVD risk of 7.5% to receive high intensity statin therapy, atorvastatin 40 to 80 milligram per day, or rosuvastatin 20 to 40 milligram per day.
Your PPT is not there, Chandan. PPT got unshared.
Okay, sir, I'm actually maybe, sir.
Okay, yeah, it is maybe because of internet. Yes, correct. Yeah. Okay, you continue otherwise then. Yeah.
So I'm here. I'm not sharing my content, sir.
Okay, yeah, it is not visible. Yeah, no, not just your name is coming and the slides are not there, but maybe net is slow, so you are not able to share your screen also. So you continue, okay. I believe, without this thing, without the presentation. Okay. Yeah.
Okay. So those with the CVD who are more than 75 years of age, or those with the diabetes mellitus, but with a 10-year risk of less than 77.5%, to receive moderate intensity statin therapy, such as simvastatin 20 to 40 milligram per day. Actually, simvastatin is not used in our practice. Atorvastatin is commonly used, or rosuvastatin is commonly used to decrease LDL cholesterol by 30 to 50%. We talked about diabetes mellitus. The type 2 diabetes mellitus is a strong and independent risk factor for coronary heart disease. So strong, risk association that diagnosis of TAP disease could be considered a coronary heart disease risk equivalent. Smoking, general consensus that smoking increases the risk of cardiovascular events. So, studies of smoking cessation demonstrate significant long-term reductions in mortality in patients who participate in smoking cessation activity. For obesity, obesity of adults are 3 times more likely to be hypertensive compared to the non-obese adults. So, all guidelines, AHA, SSC, Obesity Society have published the guidelines for the management of overweight and obesity in adults, including identify patients who need to lose weight, matching treatment benefits with the risk profiles, diet for weight loss, lifestyle intervention, counseling, and selection of patients for bariatric surgery. So these are the important points. Peripheral artery disease, treatment of hypertension in patients with a peripheral artery disease associated with a significant reduction in the risk of MI, stroke, heart failure, and death. CKD, hypertension represents a major independent risk factor for renal failure with a prevalence of 28% in hypertensive patients. In patients with CKD, cardiovascular death is more likely than the progression to end-stage renal disease. In patients with end-stage renal disease, CV is a leading cause of death, being 5 to 30 times higher in patients on dialysis than in the general population. Risk factor reduction, concomitant presence of other recognized cardiovascular risk factor results in multiplicative increase in risk of cardiovascular events. And the BP reduction with attention to other risk factors is inadequate to reduce cardiovascular risk. So the BP goal is mostly in coronary artery disease, in acute coronary syndrome, in heart failure. The BP goal should be less than 140/90. In post-MI, stroke and peripheral arterial disease, the BP goal should be less than 130/80. BP goal for management of coronary artery disease, the BP goal should be 140/190. Reasonable for the secondary prevention of cardiovascular events in patients with hypertension and coronary artery disease. 130/180 mmHg, a lower target, may be appropriate in some individuals with coronary artery disease, previous MI, stroke, or transient ischemic attack, or the coronary artery disease risk equivalent, carotid artery disease or peripheral artery disease, abdominal aortic aneurysm. In that cases, it should be 130/80. The key points and rationale behind the lower BP target, there is a continuous increase in cardiovascular risk with increasing BP levels. So the cardiovascular risk may be more related to systolic blood pressure level in older patients and diastolic blood pressure level in younger patients. So there is a J phenomena controversy, the danger of lowering diastolic blood pressure below a certain level. So there is a J curve phenomena where the cardiovascular risk increases when you decrease the diastolic pressure less than 60. And in patients with an elevated diastolic blood pressure and coronary artery disease with evidence of myocardial ischemia, the people should be levered slowly and cautiously in advice in inducing decreasing in diastolic blood pressure to 60 mmHg in any patient with a diabetes mellitus or who is more than 60 years of age. In older hypertensive individuals with wide pulse pressure, lowering systolic blood pressure may cause very low diastolic blood pressure values. This should alert in clinician to assess carefully any untoward sign or symptoms, especially those resulting from myocardial ischemia. Effects of antihypertensive treatment on coronary artery disease. Meta-analysis of antihypertensive trial have demonstrated that the BP lowering is more important than the particular drug class. Whatever the class of drug you use, your goal should be, your BP should be in your normal limit, or your goal should be met. So the risk of coronary vascular disease in patients with hypertension has been shown to greatly reduced with effective antihypertensive therapy. 10 mmHg lower usual systolic blood pressure or 5 mmHg lower usual diastolic blood pressure decreases 40 to 50% lower risk of death resulting from coronary artery disease and 50 to 60% lower risk of death resulting from stroke. So even only the 10 mmHg systolic blood pressure reduction or 5 mmHg diastolic blood pressure reduction will benefit much to prevent the risk of death from this coronary artery disease and from the stroke. The drug classes for management of hypertension and coronary artery disease are all aware. The ACE inhibitor, ARB, aldosterone antagonist, beta blockers, calcium channel blockers, diuretics. Thiazide diuretics and thiazide type diuretics, chlorthalidone and indapamide, are highly effective in reducing BP. It was demonstrated most convincingly in early studies. All there are different kinds of studies, veteran administration studies, medical research council trials, systolic hypertension and elderly programs. So benefit of chlorthalidone-based therapy in hypertension treatment is evident from ALHES trials. So beta blocker administration remains the standard of care in patients with angina pectoris, those who have had AMI, and those who have LV dysfunction with or without symptoms of heart failure unless contraindicated. Beta blocker, carvedilol, the cardioselective beta blockers like carvedilol, metoprolol, and bisoprolol have been shown to improve outcome in patients with heart failure. ACE inhibitors are the main pillars of the antihypertensive therapy, effective in reducing initial ischemic heart disease events and are contraindicated recommended for consideration in all patients after AMI. They are proven to prevent and improve both heart failure and the progression of CKD. When combined with thiazide diuretics, ACE inhibitors reduce the incidence of recurrent stroke. ARB, several ARB have been shown to reduce. We are using this ARB for a long time. And ARB are often considered to be an alternative therapy to individuals who are intolerant to ACE inhibitors. ACE inhibitors, the cough is the dry cough is a common side effect of ACE inhibitors, and in case of that case, ARB don't have that side effect. Aldosterone antagonists, spironolactone and eplerenone, lower BP alone, or when added to other antihypertensive agents, have a protective effect in patients with the chronic and advanced heart failure, in patients with LV dysfunction after AMI, and in patients with chronic heart failure and mild symptoms. Calcium channel blockers, CCB, from a hypergenous class of agents, lower BP but have distinct effect on cardiac conduction and myocardial contractility. So in ALHES, the primary prevention of cardiovascular events with the dihydropyridine CCA, the amlodipine was equivalent to that produced by the diuretic chlorthalidone or ACE inhibitors, lisinopril. Superiority over the beta blocker was claimed in Anglo-Scandinavian cardiac outcome trial, ASTRA trial. Primary protection with the verapamil-based therapy was shown to be similar to that of diuretic or a beta blocker in the controlled onset verapamil investigation of cardiovascular endpoints convinced trial. The pharmacological treatment of hypertension management of this, there are stable angina where the ACE inhibitors, the diuretics, beta blockers are main. ACS, the ACE inhibitor, diuretic, beta blocker are the main, and heart failures, the ACE inhibitors, diuretics, and the beta blockers are the main. Then the most recent trial suggests that combining ACE inhibitor and ARB is not beneficial for the secondary prevention of cardiovascular events, where combination of renin-angiotensin blocking agents with a thiazide diuretic or CCB shows important clinical benefits. Management of hypertension in patients with CAD and stable angina of coronary artery disease. Patients with hypertension and chronic stable angina should be treated with a regimen that includes beta blocker is must, ACE inhibitors or ARB must. If there is a prior MI, LV systolic dysfunction, diabetes mellitus or CKD, and thiazide or thiazide-like diuretics. So there are three combinations are important where we treat the stable angina. The combination of beta blocker and ACE inhibitors or ARB and a thiazide-like diuretics should also be considered in absence of prior MI, LV systolic dysfunction, diabetes mellitus or veterinary CKD. Management of hypertension in patients with CAD and stable angina, if beta blockers are contraindicated or produce intolerable side effects, a non-hydropyridine CCB such as diltiazem and verapamil may be substituted, but not if there is a LV dysfunction. So it's a very important point. The CCB, if there is a LV dysfunction, then diltiazem and verapamil should not be used. If either the angina or hypertension remains uncontrolled, the dihydropyridine CCB can be added to the basic regimen of beta blocker, ACE inhibitor, or thiazide diuretics. The combination of beta blocker and either of the non-dihydropyridine CCB, diltiazem or verapamil, should be used with the caution in patients with symptomatic coronary artery disease and hypertension because of increased risk of significant bradyarrhythmia and heart failure. So the non-dihydropyridine should be used with a cautious, particularly when there is LV dysfunctions or there is a chance of bradyarrhythmia. For patients with stable angina, the BP target is less than 140/90. However, a lower target BP, 130/80, may be considered in some individuals with coronary artery disease with a previous stroke or transient ischemic attack, or with a CAD, with a risk equivalent carotid artery disease, CAD, or abdominal aortic aneurysm. There is no special contraindication in hypertensive patients for the use of antiplatelets or anticoagulant drugs, except that in patients with uncontrolled severe hypertension who are taking antiplatelets or anticoagulant drugs, the BP should be lowered without delay to reduce the risk of hemorrhage. The management of hypertension and heart failure of ischemic origin. The treatment of hypertension in patients with the heart failure should include the management of the risk factors such as dyslipidemia, obesity, diabetes mellitus, smoking, diet-free, sodium, and the closely monitored exercise program. Drugs that have been shown to improve outcomes for patients with heart failure with reduced ejection fraction generally also lower blood pressure. Patients should be treated with ACE inhibitors, beta blockers, and aldosterone receptor antagonists. So the three important combinations for the heart failure is ACE inhibitors, beta blocker, and aldosterone receptor antagonists. The thiazide or thiazide type diuretics should be used with the BP control and to reverse volume and overload and associated symptoms in patients with a severe heart failure, NYHA class 3 and class 4, or those with a severe renal impairment, eGFR less than 30. Loop diuretics should be used for volume control, but they are less effective than thiazide or thiazide type diuretics in lowering BP. Diuretics should be used together with ACE inhibitors or ARB, beta blockers. Studies have shown equivalence of benefit of ACE inhibitor and ARB, candesartan or valsartan in heart failure with reduced ejection fraction. Either class of agents is effective in lowering BP. The aldosterone receptor antagonists spironolactone and eplerenone have been shown to be beneficial in heart failure and should be included in the regimen if there is a heart failure with reduced ejection fraction. One or other may be substituted for a thiazide diuretics in patients requiring a potassium-sparing agent. If an aldosterone receptor antagonist is administered with ACE inhibitor or ARB in the presence of renal insufficiency, serum potassium should be monitored frequently because the side effects of both ACE inhibitor and aldosterone receptor antagonist are to increase the potassium level. The spironolactone and eplerenone may be used with the thiazide or thiazide diuretics, particularly in patients with resistant hypertension. Hydrogen plus isosorbide dinitrate should be added to the regimen of diuretics, ACE inhibitors, ARB, or beta blocker in African American patients with the NYHA class 3 or class 4 heart failure with a reduced ejection fraction. Other may benefit similarly, but this is not has been tested. In patients who have been hypertension and heart failure with perturbed ejection fraction, the recommendations are to control systolic and diastolic hypertension, ventricular rate in presence of air, atrial fibrillation, and pulmonary condition, and peripheral edema. Use of beta blocking agents, ACE inhibitors, ARB, or CCB in patients with heart failure with preserved ejection fraction and hypertension may be effective to minimize symptomatic heart failure. In ischemic heart disease, the principle of therapy for acute hypertension with pulmonary edema are similar to those of STEMI and non-STEMI, as described above. If the patient is hemodynamically unstable, the initiation of these therapies should be delayed until stabilization of heart failure has been achieved. Drugs to avoid in patients with hypertension and heart failure reduced ejection fraction are non-dihydropiridine calcium channel blockers such as verapamil and DPNA. So whenever here the echocardiography is very important to understand whether it is a reduced ejection fraction heart failure or preserved ejection fraction heart failure. And then clonidine, moxonidine, and hydrogen without a nitrate. So these are drugs should be avoided, like non-dihydropyridine, calcium channel blocker, clonidine, moxonidine, hydrogen without a nitrate. Alpha blockers such as doxorubicin should be used only for the drugs for the management of hypertension and heart failure and inadequate to achieve BP control at the maximum tolerated. NSAIDs should also be used with caution, you all know, because it increases the water content in our body. So fluid retention is one of the important side effects of NSAIDs. The target BP is less than 140/90, but consideration can be given to lowering the blood pressure even further to less than 130/80. In patients with an elevated diastolic pressure who have coronary artery disease and heart failure with evidence of myocardial ischemia, the BP should be lowered slowly. in older hypertensive individuals with wide pulse pressure, lowering systolic blood pressure may cause very low diastolic value. So that could be causes. This could alert the clinician to assess carefully any untoward sign of symptoms, especially those caused by myocardial ischemia and worsening. Octogenarians could be checked for the orthostatic changes with standing, and systolic blood pressure could be less than 130 mmHg, and diastolic blood pressure should be 65 mmHg should be avoided. So in that group of patients, you keep your blood pressure, you keep your blood pressure high. So more than systolic blood pressure should be more than 130, and diastolic blood pressure should be more than 65. So 2017 ACC and AAPA different guidelines for the prevention, detection, evaluation, and management of high blood pressure in adults. In adults, the stable ischemic heart disease and hypertension BP target of less than 130/80 is recommended. Adults with stable ischemic heart disease and hypertension BP more than 130/80 should be treated with medications, beta blocker, ACE inhibitors, ARB, compelling indications of previous MI, stable angina as first-line therapy, with addition of other drugs like dihydropyridine, calcium channel blocker, thyroid diuretics, or mineralocorticoids as needed to further control hypertension. The recommendation of treatment of hypertension with stable ischemic heart disease in adults with ischemic heart disease angina and persistent. This is the level of evidence is low level of evidence. And persistent uncontrolled hypertension, the addition of dihydropyridine, calcium channel blocker, beta blockers is recommended in adults who have had a MI or acute coronary syndrome. It is reasonable to continue beta blockers beyond 3 years as long-term therapy for hypertension. And there is a level of evidence is C. This beta blocker and calcium channel might be considered to control hypertension in patients with coronary heart disease without heart failure, reduced ejection fraction heart failure who had MI more than 3 years ago and had angina. Management of hypertension is patient with the SIHT, reduced BP to 130/80 mmHg with the beta blockers, ACE inhibitor, or ARB. BP goal not met, angina factors are there, then add dihydropyridine, calcium channel blockers if needed, that is class 1, and add dihydropyridine, calcium channel blockers, thyroid diuretics, or MRA is needed. Then heart failure, the recommendation for in adults increased risk of heart failure, the optimal BP in those with hypertension should be less than 130/80. And the adults with heart failure of reduced ejection fractions and hypertension should be prescribed with titrated to attain BP of less than 130 mmHg. So there are low level of evidence that in the non-hydropyridine calcium channel blocker are not recommended in the treatment of hypertension in adults with reduced ejection fraction. So it is repeatedly explained here that non-dihydropyridine calcium channel blockers are not recommended in the treatment of hypertension in adults where there is a reduced ejection fraction heart failure. Heart failure with preserved ejection fraction. In adults with preserved ejection fraction present with symptoms of volume overload, diuretics could be prescribed to control hypertension. Adults with preserved ejection fraction heart failure, persistent hypertension after management of volume overload could be prescribed ACE inhibitors or ARB and beta blocker titrated to attain systolic blood pressure less than 130 mmHg. So healthy heart is necessary for healthy life. Keep your heart healthy. Thank you for listening to me.
Thank you, Chandan. We could not see your slide, but we could manage. And now we have Dr. Ajay Kumar Sinha sir also with us. So yes, I think without wasting much time, our sir doesn't need any introduction. He's our professor of medicine from NMCH. He's a very important nodal officer for COVID now, with this pandemic of COVID-19 for last since we know it from January itself. And sir is also nominated awardee for RSSDI award for special situation in COVID and its management. Hopefully, I think RSSDI central body is going to accept our nomination from state, because sir has not only risk his life, otherwise he has shown his daredevil heart to all the doctors and made a mark on history of COVID pandemic in Bihar. So I think without wasting much time, I'll request sir to start his deliberation on heart failure in Indian population. And it's a great pleasure to have you, sir, as our speaker. Over to Ajay, sir. You need to unmute, sir.
Thank you, Dr. Subhas, our secretary, and thank you for your good words that I need at this point of time. Of course, the fear from the COVID is going down, but still we are fighting with the COVID, and certainly these kind of words will put me more energy, and I will pass it to my all those 1,200 members who are still struggling against the COVID-19, keeping in mind that the resources are limited. So thank you very much, and I thank IPCA people for giving me opportunity to revise my knowledge for one of the most common disease which we are witnessing nowadays, in particular with diabetes. And if we are not aware that how to tackle this situation, we may miss this condition that is known as heart failure. Now I am going to present before you the
Can I share your slides, sir?
Yes. Are you not able to see my slides?
No, sir.
Okay, let me try.
Can I share your slides?
Okay, you can.
And you just tell me next. I can do that.
Okay, let me do first.
Okay, sir.
Let me try first, so that will be easier for me.
Yes, it is coming now.
Yeah, sir. It is visible, sir.
Just need to put on presentation mode, I think. It's done. It has come, sir.
Okay. Are you able to see me?
Yes, sir. Yes.
Yes.
Okay. Okay. Thank you. So, camera. Okay. All right. I am visible. So sorry for delay, technical delay, which I am not aware about, not so tech friendly. So today I am going to revise my knowledge as well as your knowledge about the heart failure in India. Before that, what is the still and what is the challenges and how important this problem is? We all know that heart failure is not a disease. It's a syndrome. It's a kind of symptom complex. And there are many diseases behind it which produces the heart failure. Now, the burden of heart failure is large. If you see the globally, it has become also one of the common clinical syndrome, and the globally it has been accorded the good health priority nowadays. the burden of the heart failure is increasing at an alarming rate worldwide and also in India. Heart failure increases the risk of mortality, morbidity, and worsens the patient quality of life. Heart failure puts a huge burden on the overall healthcare system. And the thing is that we receive this deadly disease, heart failure, in a very uncommon way, because many of the patients which are coming for consultation, they will tell us that yes, he is feeling a kind of weakness, tiredness, and if I walk, I feel some kind of tiredness and sometimes shortness of breath. So if the clinician is not aware of its importance, he might miss it. And we know that the not only morbidity is high, the mortality is high. The sudden death is very common as the failure is seriousness is increasing. So is the number of the sudden death in this disease. So that we have to remember. So being a serious disease it presents in a very simpler way. So unless until we are very aggressive, we will be not able to diagnose this case at right point of time. Now, what is the global burden of heart failure? The heart failure has emerged as a major global health issue with an estimated worldwide prevalence of 3.7 crore. So huge number of patients nowadays are suffering from this deadly disease, heart failure. And the burden is rapidly increasing, and it is projected that by 2030, the number of heart failure patients would still rise by 25%, knowing the fact now we have some drugs to take care of this heart failure situation. Still, the scientists are predicting that it will further increase by the hefty margin by 25%. We all are aware that mortality rate is 50% at 5 years from the initial diagnosis of heart failure. And nowadays, heart failure is the leading cause of hospitalization and represents 1 to 5% of total hospital admissions. And it is just said that about 2 to 17% of heart failure patients admitted to hospital die while in the hospital, and patients who survive have a high rate of rehospitalization and poor quality of life. And those clinicians who are working as a physician or diabetocardiologist, they are receiving large number of cases of heart failure. And if once again, I am highlighting that if we are not aware about the symptomatology of the heart failure, we might miss at a right point of time. So Indian data is not very high. There are some smaller studies, 5-6 studies, they have done it to know the prevalence of heart failure. And the current estimates about incidence of heart failure in India vary widely from 1.3 to 23 million, 2 crore. So if we consider the population of Bihar, we have enough number, at least 10 lakh patients are suffering from heart failure in our state. There is a registry which is called as Trivandrum Heart Failure Registry, and they have reported that heart failure with preserved ejection fraction. We know that mostly we diagnose heart failure early by taking the help of echocardiography, and there are one distinct entity that has emerged is heart failure with preserved ejection fraction. Previously, we were diagnosing heart failure only those cases which has got the heart failure with reduced ejection fraction, but now they have pointed out that heart failure with preserved ejection fraction accounted for 25% of the total heart failure burden, even more, indicating that in Indian clinical practice, of course, HF with reduced ejection fraction is observed, but yes, there is an equally good number of patients who are having the preserved ejection fraction kind of heart failure. Heart failure is a major health problem in India with a post-admission mortality of 20 to 30%. Now, this is a study which has been carried by the AIMS group. This is a known as India UCRI study, and they have done study a kind of registry where they have taken the All India Institute of Medical Sciences Cardiology Department and the 6-7 adjoining village, and they have diagnosed based on the clinical pathology and echocardiography, and they found that prevalence of heart failure is 1.2 per thousand rural population, and with 2/3 suffering from diastolic dysfunction and 1/3 systolic dysfunction. We know well in our practice, even in diabetology, if we will go for the echocardiography, a good number of patients will come with grade 1 diastolic dysfunction. So diastolic dysfunction at an early age, at the age of 40 to 50, definitely shows that this patient might land up into the heart failure. And hospital data, which they have collected at All India Institute of Medical Sciences, they have found that 20% patient came with heart failure, and in a cardiology clinic, 20% out of all cardiac patients, they have received 20%, 1 in 5 patients who were suffering from heart failure, and the causes were mostly they have received the causes from rheumatic heart disease, and second by ischemic heart disease. This was his recommendation, his observation. But the other study which have been conducted in private hospital, they have found the most important cause of heart failure was in their hospital was ischemic heart disease. Key facts regarding heart failure in India, which has came through the V. Chaturvedi work, which has been published in Journal of Cardiovascular Science in 2016. Once again, this is known as India UKRI study. So this has given that admitted patients are very sick. Means most of the patients are coming to hospital in a late phase of their life cycle. 1/3 die during admission. If discharged, 1/4 more die in the next 3 months. The most common causes are RSD and CAD. The RSD burden was 0.25 to 0.3 million, a good number of patients. 20% gets heart failure with 3% annual mortality. Coronary heart disease, which has emerged one of the important causes in India, of course, globally, the coronary heart disease is going down, reducing. Prevalence of coronary heart disease is reducing globally in developed countries, but in India, it is on the rise. And a large number of patients who are having ischemic heart disease presents with symptoms of the heart failure. So burden is almost 2 crores, 3 crore patients are having coronary disease, and 30-day heart failure rate is 5%. Hypertension is one again important cause of leading to the heart failure, and they have found in this study that 25 to 40% were in urban, 10 to 15% in rural, with total 118.2 million, means 11 crore, more than 12 crore people were suffering from hypertension in India, and out of that 5 to 10% get heart failure. It was his observation based on their study. But overall, important causes of the heart failure, which emerged through the India UKRI study, was the number 1 was rheumatic heart disease, number 2 was ischemic heart disease, number 3 was hypertensive heart disease, number 4 was dilated cardiomyopathy, number 5 was congenital heart disease, number 6 by the core pulmonale, means the COPD and other disease. But if you see if you combine the ischemic, hypertensive, and dilated, which is very common in diabetes, you will find that a good number of diabetic patients end up into heart failure. So any diabetic patient at the age of 60, he is complaining of tiredness, or if he is complaining of shortness of breath after exertion, we don't have to miss that this patient is suffering from heart failure. Challenges related to heart failure: improper control on factors likely to increase incidence of heart failure in India. We have a large number of aging population, because after independence, we know that after independence, our life expectancy has grown more than double. Now the life expectancy has become from 34 years to 67 years. So we have a good number of, every year we have increasing aging population, rising coronary artery disease prevalence, epidemic rise of key risk factors such as hypertension and epidemic diabetes mellitus, persistence of disease such as RSD and untreated congenital heart disease, and rising burden of lung disease because of the population or other things. So all these things are very relevant to lead to increased number of heart failure in India. Now, challenges related to heart failure in India. The medication adherence, medication adherence ranges from 25% to 50%, and even less. And the tolerance of guideline based is low for Indian patient, not only the inertia from the patient, also the inertia from the clinician itself. So, and we know that contrary to the Western world, in India, the average person has to bear the cost of the therapy, meaning by the out-of-pocket expenditure is high. And the economy, we know we have the diverse economy. So that's why there is, and the drugs are a bit costly, newer drugs. So there is a difficulty in medication adherence. And we know by now that some of the devices have come up to take care of the serious case of heart failure, like ICD, like CRT, and sometimes we need LVAD, left ventricular assist device, before transplantation. So the devices are not only very costly, but also the availability is less. And since I am working in the government sector in Bihar, we have very less number of the ICD, keeping in mind of the large number of heart failure, stage 4 New York classification, when they need the CRT, but we have very few number of patients who were put on CRT devices to take care of the heart failure. These are the heart failure different studies they have conducted, and what they have found. It is a busy slide. There was 3, 4, 5 studies they have done, especially to find out the comorbidity in heart failure. So the one was the Asian sudden cardiac death in heart failure, Indian subset data. All are new data, and the Trivandrum heart failure history, practice innovation and clinical excellence, Pinnacle India Quality Improvement Program, International Congestive Heart Failure, Indian patient data, Medanta registry. So these 3, 4, 5 study they have conducted, and they found at the end that the comorbidity associated with heart failure was CAD. Some study have found the CAD as the highest number. The other is hypertension and diabetes mellitus. This is a common comorbidity. So if you are practicing as a diabetologist, good number of your patients might carrying the incipient heart failure. So that you have to take into account. So you see one study is in sudden cardiac death in heart failure. They have analyzed, they have found that 3 most important causes leading to the heart failure was CAD, hypertension, and diabetes mellitus. Other was CKD, COPD, some arrhythmias. Some study has shown same hypertension, CAD, diabetes mellitus, myocardial infarction, COPD, heart failure. So almost all 5 studies have found common disease behind the development of heart failure was diabetes mellitus, hypertension, and coronary artery disease. So what is the importance of comorbidities? Why we have to look for comorbidities? Comorbidities in patient with heart failure. They interfere with the diagnosis process of heart failure. Like if a patient suffering from COPD, they will give same kind of symptom, cough and shortness of breath and tiredness. So this they will act like a confounding factor. So if we are not very particular about it to find out the symptom and signs and diagnostic work of heart failure, we might miss the incipient heart failure. So that's why the comorbidity becomes a confounding factor. Sometimes they aggravate heart failure symptoms, like if the patient has got the arrhythmia, so that will increase the symptoms and further impair quality of life. They will contribute the excess burden of hospitalization and mortality as the main cause of readmission at 1 and 3 months. May affect the use of treatment for heart failures, because if the patient has got the severe renal dysfunction and they are carrying the heart failure too, so it becomes challenge to put the renin-angiotensin system inhibitors, which we know that this is the #1 drug to be used in heart failure. Drugs used to treat comorbidities may cause worsening heart failure. Like if the patient has the rheumatoid arthritis, and if we are giving the NSAID, another drug which is having the sodium in their formulation, they will aggravate the heart failure. And interactions with drugs used to treat heart failure and those used to treat occurrence of side effects like beta blockers. It's a indicated drugs in heart failure with reduced system fraction. But if the patient is having the COPD, or asthma. So sometimes it becomes difficult to manage the symptoms of both the drugs on both the diseases with the drugs. So comorbidity has got its own important. How are Indian heart failure patients different? Indian patients present with heart failure at an younger age than those in the West. In Western people, mostly they become the patient of heart failure at the late age. But in India, it's 10 years earlier. Male to female ratio is also different in India, 72 to 30 compared to USA and Africa, almost 50-50. RHD is still important disease in India, but not in the United States. Diabetes mellitus is more prevalent among Indians than those in the West. Prognosis of heart failure in Indian patient appears to be worse because of various reasons than those in the West. Heart failure strikes patients in the prime of their lives in India, and majority of the Indian patients have to spend out of pocket for their treatment, unlike in the West, which I have mentioned earlier. So what to do? What is the simplest way to keep remembering the algorithms for diagnosis of patient with chronic heart failure? We have to know the signs and symptoms, what tiredness, weakness, sudden tiredness, sudden shortness of breath after exertion, kind of things, palpitation, giddiness. So if the patient is giving in the background of comorbidity, we have to think about it. We have to do the physical examination. We have to see the JVP, edema fit, the pulse, arrhythmia. So in that way, we have to take the physical examination, and we have to do the basic blood investigation. ECG will help sometimes, but if the patient has hypertension and if he has got abnormal ECG, probably hypertension is the cause of heart failure. Chest X-ray will put the cardiomegaly or with oligemia or plethora. If the patient has got congenital heart disease, we will have the oligemia kind of things. Echocardiography is a seat anchor in the diagnosis. So echocardiography, we take into account into echocardiography, 2D echocardiography, but sometimes 2D echocardiography might not visualize all part of the ventricle, so posterior part might be missed by echocardiography, but yes, it is a good tool. But nowadays, the better version of echocardiography has come up, like 3D, and they give a wonderful result about the heart failure, and they not only diagnose only heart failure, they classify the three important subtypes of heart failure: preserved ejection fraction, reduced ejection fraction, or mid-range ejection fraction. And by looking the left atrium size and looking the LV mass, we can predict that what kind of heart failure we are dealing with. So based on that, and the one important biomarker which has emerged, I usually take into account when I am busy seeing large number of patients with a constraint of time. So BNP will tell us whether we are dealing with heart failure or not. So if the BNP is normal BNP almost rules out the heart failure. So that is a catch point. So BNP, if it is a less than 100, probably the patient is not having the heart failure. And there are three types of heart failure, which I have already described to you. The heart failure with reduced ejection fraction, less than 40%. Heart failure with normal ejection fraction, which is known as preserved ejection fraction, or more than 50%, which is a normal, 52 to 53%. And in between the range, the newer subtypes have emerged nowadays, and it has put the attention of researchers, the LBF 40 to 49%. And still there are some cases where usually based on this, we will not able to say that this patient has got heart failure, but it is a very less number of patients. So utilizing all those things. But if not, there are other methods like cardiac MRI and all other things. But it doesn't require, mostly it is a diagnosed heart failure only by this algorithms. And it's not that what we do usually, we combine all those cocktails and we put it to heart failure patient. But like diabetes, we know nowadays we have a lot of targets. It's not HbA1c reduction, but there are many targets, and achieving the targets leads to benefit so far the prevention of microvascular and macrovascular complications are concerned. So is the case in the diabetes. So we have to remember 7 points. The heart rate should be brought to less than 70. That's a very important, either through the beta blocker, if contraindicated by using evaporating. The blood pressure should be brought down to less than 130 by 80. HbA1c should be brought down to less than 7%. Hemoglobin is better to keep it above 12 gram. BMI, which is possible, and the finally 6-minute walking distance by the use of diuretics and by use of the other drugs. So if the 6-minute walking distance is more than 400 meters, and we have maintained all those things, probably we have got success in heart failure, and probably we are going to increase the life of the patient who is suffering from heart failure. Lifestyle modification, like diabetes, lifestyle modifications are very important. Fluid intake should be reduced, especially those patients who are suffering from advanced heart failure, NYC class 3 or 4. Avoid or EF is less than 25%, severe heart failure. Avoid alcohol in patient with alcoholic cardiomyopathy. Limit salt intake, it's very important. Maintain normal weight and exercise with graded exercise under the guidance of the physiotherapist is a good. But yes, if the patient has recovered just now from the newer class heart failure class 4, one has to be very, cautious by doing some active exercise. So it's better to take help from the specialists who are taking care of the exercise part. So this is about the pharmacological management of heart failure. Just I will revise you that there are conclusive evidence in favor of certain drugs. There are not still evidence in favor of certain class of drugs. So if you see heart failure with preserved ejection fraction, we have very less number of drugs which have been proved to be used and to increase the survival part. Of course, we are using diuretic if the patient is coming with the heart failure. So diuretic is the number one, but it doesn't prolong the life of the heart failure patient. There are other drugs, the beta blockers and mineralocorticoid receptor antagonists, and it's for only symptoms improvement. So we must so we must remember that we have to treat heart failure preservation patient, but we have still not sufficient evidence to say with confidence that when we are using this drug, it will prolong the survival. And of course, vaccination has got role. So this is immunocompromised condition. So it's better to take vaccination at least for pneumonia. And if the person is having COPD, so they have to take for the influenza vaccination. Similar is the situation with the heart failure with MR mid-range ejection fraction. So treatment is done for only the background diseases which has led to this. But as we are well aware that the heart failure with mid-range ejection fraction will not lead to symptoms. So these both groups will not lead to symptoms. So we don't have to worry about it, but yes, we have to worry about the comorbid situation to check those comorbid situation. If the patient has got hypertension, if the patient has got diabetes, we have to control in aggressive way so that the further progression of this serious disease can be prevented. Yes, this is a heart failure with reduced ejection fraction. So this class is important, and we have used ACE inhibitor, but now we have, after the paradigm HF trial, we have also had a sacubitril combination. So we are using this, and recently we have also got another new class of drug which can be used in both in diabetic or non-diabetic patient, the dapagliflozin, to have better effect on the heart failure. Recently concluded some good trials has shown some newer drug for the benefit of heart failure patient. Beta blocker, yes, beta blocker has to be used, not on those patients who are having newer class 4 kind of patients, but beta blocker should be indicated, is indicated, and it should be used with the maximum dose, tolerated dose, not that just by putting only 12 or 25 milligram of drug, as he tolerates, or till the pulse rate becomes less than 70. One can add mineralocortical receptor antagonist, and diuretics, as I have told you, that this does not increase the life of the patient. So it should be used as for the dying of the patient if the patient is having congestion or edema or kind of things. Vaccination is important. Other drugs is a supporting drugs like ibuprofen, digoxin, hydralazine, isosorbide dinitrate, drugs for as per comorbidities. So IV iron, statins, oral anticoagulants. So these drugs should not be combined in every patient, but as the background diabetes diseases are different, so one can use selective use can use this class of drugs. There are many other drugs which are of uncertain value and not proved, and there are drugs which has got the harmful like thiazolidinediones, NSAID or coxetine inhibition, diltiazem, so they should be avoided and they should be used, but they do not have any good number of papers to suggest that this is useful. The core drugs are ACE inhibitor, ARNI, beta blockers, MRA directives, ibabradine, along with the SGLT2 inhibitor, and other drugs are this, as I have already pointed out. So the algorithms, finally, before I conclude my talk, the algorithms for heart failure management is all symptomatic patients with chronic heart failure. First, after diagnosis, first we have to diagnose. Once we have diagnosed, are treated with ACE inhibitors and beta blockers titrated to maximum dose. Nowadays, ARNI or SGLT2 inhibitor. Instead, ACE or ARB may be used. AHA guidelines recommend that ARNI can even be started in the initial stage of heart failure. Directives including mineralocorticoid receptor are added. Still symptomatic, then add ARNI instead of ACE inhibitors. One has to withdraw ACE inhibitors and then add the ARNI. And if heart rate is above 70 per minute, then add ibabradine in addition to beta blockers. Yes, if QRS is more than 130, and if the patient is suffering from reduced ejection fraction type of heart failure, the use of CRT is helpful. That has been proved by some of the trial like MEDITACH trial. If still symptomatic, consider digoxin and isosorbide and hyaluronic combination. If not, prepare for patient for heart transplant, and in between, one can use the left ventricular assist device. If AF is less than 35%, in ICD, because sudden deaths are very common in this kind of patients, so ICD may be considered in ISD and with certain qualifiers and dilated cardiomyopathy. So recommended doses of various antihypertensive, I will not go in detail, only I will highlight the beta blockers. So if you are giving beta blockers in heart failure, you start with 12.5 milligram of drug and go up to 200 milligram of OD if the patient tolerates it, or if the patient heart rate has gone below 70 per minute. So it's not that only giving 25 or 50 milligram is enough. One has to always count, and this is a device therapy. As you know, as we all know that in heart failure, sudden deaths are very common. So there are three groups of patients: the asymptomatic heart failure, the NYHA class 2-3 patient, and the symptomatic class 4 patient. What to do? So if the asymptomatic heart failure patient, but yes, the patient has suffered from myocardial infarction 40 days before, and ejection fraction less than 30%, and he had optimum medical therapy he is taking and is still symptomatic, and the life is more than 1 year. So life is more than predicted life survival. Predicted survival is more than 1 year. Then it's better to add the ICD. It's a kind of machine which sense and which defibrillates. The one lead is placed in one chamber like atrium or ventricle, the other in the ventricle. And if patient is symptomatic, class 2 and 3, ejection fraction is less than 35, QRS is more than 150, and use optimum medical therapy. Either use CRT or use ICD. There is slight difference. There is a sensing. This is a kind of pacing done on both chambers, ventricle, and this is only one sensing, another defibrillator had done. It is for prevention from the sudden cardiac death, and it is for the benefits, symptomatic benefits. And if the patient is symptomatic class 4, so either temporary or permanent ventricular assist device and put this patient for heart transplantation. No, nothing more less than heart transplantation will work for symptomatic class 4 patient, and ICD deactivation. So what is Indian guidelines on hypertension 2019? Selective beta blockers such as metoprolol, bisoprolol, and beta blocker carvedil may be used in patients with congestive heart failure, stabilized with ACE inhibitors and diuretics. And now the two drugs which we are adding nowadays, one is the ARNI, sacubitril valsartan combination, and the second, which has recently emerged as a successful drug for diabetes or non-diabetes, is SGLT2 inhibitor. So to conclude, the burden of heart failure is increasing at an alarming rate worldwide as well as in India. It's a major public health problem in India, with a post-admission mortality of 20% to 30%, and morbidity is very high. The most common causes are RSD and CAD, and diabetes has also emerged one of the important precursor to have the this a deadly condition. The improper control on factors like likely to increase incidence of heart failure in India. Medication adherence and poor availability of devices are also increased chance and symptoms of heart failure in India. Indian heart failure patients are different from Western countries in various aspects, and comorbidities may worsen heart failure patient condition. So keeping in mind of the population, India comprises of 16% of the global population, but 30 to 40% of the heart failure population. Thank you very much for patience hearing. Thank you once again.
Thank you, sir. I think it was a real extensive presentation of a complex topic. And we certainly have a lot of doubts, and it was cleared. And earlier we used to think heart failure is a thing which is very not of much concern, and only ischemic heart disease cases will land up in heart failure. But certainly nowadays we have this problem with many of patients which you never used to detect early with diabetes and all those breathlessness and fetal edema. It used to go for either neuropathy or asthma or some kind of thing, but now we are becoming more and more vigilant. And as your presentation cleared us that we should look at the symptom and have to detect it earlier so that we can prevent with the newer drugs like ARNI and SGLT2 inhibitors. How to get the question, Sunil? If there is any question for the speakers, you can.
Mr. Chintan, is there any question in the chat box?
Just by the time you find the question, I'll ask Chandan one question. What kind of scoring you use, Chandan, in your clinic to have a risk of CAD in hypertension patient? As it was your presentation, that what scoring system you use in your clinic for CAD?
Sir, ACVD risk calculators which are available online, calculators available. I think I am using that calculator.
Okay, so that is a really practical thing to use.
Yeah.
Because we could not see on the slide because of the technical.
Actually, in slides, sir, that was the Birmingham scoring was there, but I'm using ASCVD calculator in my practice. What's your opinion, sir, Ajay, sir?
Dr. Subhas, you know that the prevalence of heart disease were increasing in the United States and many parts of the world. So they all designed a scoring system, and that is a mass screening program. So for mass screening, to select the patients of the coronary heart disease from the mass, they have designed a scoring system. So previously, with the government funding, they have designed a Birmingham risk scoring system. It was a mass kind of program, but when the hypertension group of the people, they have met together in 2017, if I correctly remember, they put another scoring system, ASCVD scoring.
Yes, sir.
That is on your mobile. That is on your mobile, so you can predict yourself what is the risk of suffering from coronary heart disease. And
but sir, sir, there is actually it is only for more than 45 years of age group, sir.
Yeah, but
yes, sir. ACVD, your risk factors calculator is used for only more than.
So that will give you kind of a hint. So it's a very easy. So you will put all those, whether you are having diabetes, smoking, like this. So there are 6-7 points, but put on that, and that will give you idea that how much risk you are carrying, and based on that, what prevention program you need. So besides taking care of all those situations, you have to take care of that weight and lifestyle. You have to take the statin, because you know the statin has emerged one of the most important modifiable risk factor with the patient who are having high risk of coronary heart disease. And with those risk scoring system, you are well aware that the prevalence of the coronary heart disease is decreasing in developed countries. India is on the rise on the other side. So they have given, but yes, they have given the CBD risk scoring system. There were debate, there were some hot discussion among the scientists all across globe. But yes, it is a tool, simple tool, and you can put on the diabetic patient that yes, what is your risk score, is CVD risk score, which is the recent score for you. So it has taken care of both the Western people and Indian people too. So you can also have, and it is said that the risk for the Indians are even more. So if you have
Yes.
found that the risk is less than 7.5%, you have to multiply it by 2, and based on that you have to give either the moderate intensity statins or aggressive statins to those particular patients.
Yeah, the idea was of asking this question to you that do you show this risk score or to your patient, and you say that okay, you have a score of 10 or more than that. So based on that, I want to prescribe you a statin which is of either moderate or high or low intensity. Like in your practice, that's what the point of asking is whether you are using it, and are your patients are accepting the way you explain depending on the risk score?
No, to me,
Oh, Chandan sir, I was just asking Chandan whether
Sir,
he has presented very well.
sir,
So that's
sir,
whether it is just a knowledge or a practice
no,
which
sir.
we want to learn.
In some patient who is very educated patient, since I'm doing my practice in RPS area, Belly Road area, which is very almost a very upcoming area, and there are a lot of patients who are very well educated and the well knowledgeable patients. In that patients, for their education purpose and for their counseling purpose, I use this tool, and for some patients, and in some patients I use for myself.
Yeah, very correct. What Chandan has told is correct. It is exactly in the same way what I am doing practice. Because it was there was a time when people were not ready to accept anti-diabetic drugs. No,
Yeah.
I don't need. I need Ayurvedic medicine.
Yeah, sir.
Do it.
Right, sir.
But with the good mass media nowadays, now people are
Yeah.
some of the people are coming. Check kar lijiye pura mera. Even if the
Sir.
patient got nothing.
Yeah.
So those health conscious patients or those patients who are very tough to treat, then I
Yeah.
say, if you are educated, go on Google, see your CBD score. It's very easy.
Yeah.
And see, if you will allow me, I will do your scoring system. Your scoring is so you have to take. And many patients will ask you, why you are prescribing me statin? I don't need a statin. So on those, and you need that. No, this patient needs a statin. So in those, and many of the patients will ask you, कितना दिन खाना है? In our practice also, कितना ये जो दवा आपने नहीं लिखी, तो डायबिटीज की दवा नहीं है, कितना दिन खाना है? So for those patients, I put this as CBD scoring system. And yes, some of my patients, they are taking statins based on the scoring system.
Any question, Rajiv ji?
No, sir. There is no question on the chat box. I have asked Chintan. Says there is no question on the chat box, sir.
Okay, then over to you now because
yeah, sir. Thank you very much, sir. And I must thank you on behalf of IPCA, Dr. Subhash Kumar, sir, Dr. Chandan Kumar, sir, Dr. Ajay Kumar Sinha, sir, for his wonderful presentation. And I also thank all my audience for active participation, sir. Thank you very much, sir. Thank you, sir.
Thank you. Thank you all.
Thank you.
Good
Thank
night.
You. Pranam, sir. Pranam, sir.
Thank you, sir.